You are listening to Radio Maria Canada. We now present the Health Hub, hosted by Kathy Biasi.
Welcome to the Health Hub on Radio Maria Canada, exploring cutting-edge health and wellness information and therapies, helping you to take your health to the next level. I am your host, Kathy Biasi, and I am a holistic nutritionist and a professional cancer coach. This week on the Health Hub, we are talking about a functional and integrative approach to treating osteoporosis with Dr. Keith McCormick. Dr. McCormick was diagnosed with severe osteoporosis at the age of 45, and his healing journey led him to become a world expert on treating osteoporosis. Dr. Keith McCormick is a board-certified chiropractic physician in the states of Massachusetts, Colorado, and California, and he has been in clinical practice since 1982. He is passionate about helping individuals with osteoporosis regain their skeletal health through a functional medicine approach. In 2011, he founded Osteo Naturals, a company dedicated to providing information and quality nutrition products to individuals with bone loss. Dr. McCormick earned his bachelor's degree in human biology at Stanford University and his doctorate at the National College of Chiropractic. He's an instrument-rated commercial pilot and a U.S. Army veteran. Sports have always played a vital part in Dr. McCormick's life. At Stanford, he competed in the varsity cross-country and fencing teams. As a junior, he was a silver medalist in the 1973 Modern Pentathlon World Championships. Then in 1975, he won the North American Championship, and the following year was a member of the United States Olympic Modern Pentathlon team that competed in the XXI Olympiad in Montreal. He is the former U.S. record holder for most points scored in a pentathlon competition. Dr. McCormick continues to compete in triathlons of all distances and has completed 6 Ironman competitions, 5 of them after recovering from multiple osteoporosis-related fractures. He is the author of Osteoporosis, Integrating Biomarkers and Other Diagnostic Correlates into the Management of Bone Fragility, The Whole Body Approach to Osteoporosis, and his newest book, Great Bones, Taking Control of Your Osteoporosis. I learned so much from speaking with Dr. McCormick. We talked about the role of inflammation in osteoporosis, fatty bone marrow and osteoporosis, something I had never heard of, key laboratory testing for patients with osteoporosis, dietary life and lifestyle interventions to manage osteoporosis. Just so many things came out of this podcast, this conversation with Dr. McCormick. Really, really a great listen. So I do hope you can stick with us. We will be back in just a few minutes to talk with Dr. McCormick.
You are listening to Radio Maria Canada. We now continue with the program, The Health Hub, hosted by Kathy Biasi.
Welcome back, everybody. Today's show has been recorded, so no opportunity for calling in. Please do follow us on our social sites. We are on Instagram, Twitter, and Facebook, and we are at the Health Hub RMC on those locations. Dr. McCormick, welcome to the show. Thank you so much for joining us.
Thanks for having me, Kathy.
Yours is a very interesting story of how you became such an expert, somebody who's called upon very often in this field. Can you tell us how you got here? What was the impetus for this space of work you're in?
Well, as often is the case, when somebody wants to find answers to something important to them, they dive headlong into the issue, and that's what I did. So back in I'm not sure how long ago, but when I was 45, I found out I had osteoporosis, and I started breaking a lot of bones. And so I went to several endocrinologists, and they just wanted to put me on drugs. And I said, well, I'm 45 years old. If I live to be 90 or so, that means I'm going to be on drugs for 45 years. And they said, yep. And I go, well, that doesn't seem to make sense. So I said, let's try to figure out what's going on. And that's why I just immersed myself in the study of osteoporosis and became fascinated with it. And that's where I am right now. So,
well, with respect to your own case, it is quite unique, isn't it? I mean, a great athlete, a male, and I'm going to go on a limb here and say that it affects females more than men. Is that correct? We'll start that parameter off right away. Yes,
definitely. It's 50% of women will get osteoporosis and 16 to 20% of men. So, and yes, I was an athlete. I was a male. I was young, 45. I had never taken any medications or drugs of any kind. So it was very unusual. And it definitely threw the endocrinologists that I saw for a loop. They didn't understand what was going on either. So yeah, highly unusual.
Is this a clear story of genetics?
Nope, no genetics involved that I know of. My parents didn't have osteoporosis. My brother didn't have osteoporosis. So I think, what's an important lesson from that is, yes, there are things that increase a person's risk for osteoporosis, but because so many people get osteoporosis, everybody should be assessed. Everybody should have a bone density, and not when they're 60 years old, but at a younger age. At least by 50, 55, everybody should have a bone density.
Now, the biggest space you're in is for those that are suffering with osteoporosis, right? You're not the prevention piece. Yes, I'm sure is probably part of your practice to some point, but where you're entrenched, my understanding is with people that have been diagnosed.
Yes, I get lots of patients who have been diagnosed, and they're very fearful, as they should be, because, it can really crimp your style to get fractures, spinal and hip fractures. And, a lot of people come to me and they're incredibly upset because this is a surprise. They say, one of the things people say to me all the time is, but I've eaten well in my life. I've exercised. I've done everything right. And now I come up with this osteoporosis diagnosis. But the truth is, a lot of people have bone loss, not only ongoing bone loss, but they never probably reached a peak bone mass when they were younger, which puts them then at a deficit when they get older.
Can you look back in a history of a person or do you look back at the history of a person and try and see what factors may have contributed to it, or is that a moot point?
Oh, no, it's definitely not a moot point, because it's an incredibly important point to do, because what I'm trying to do is two things. Number one, get a person out of trouble right then, and then make them better, for the rest of their life, improve them. So if we don't know how they got into this fix to begin with, then it's harder to figure out what to do to improve their overall and skeletal health.
And you successfully can go back in most cases and, get the history and see where the inadequacies have been?
Certainly not in every case. We don't know, but yes, it's pretty easy, I guess, to say, well, geez, this person smoked a lot, or this person is gluten sensitive, or this person, didn't start having her period until she was 17 years old, and then she had intermittent periods for their life. There's just so many things that can lead to bone loss or decreased bone density, increased fracture risk, that those things can oftentimes be determined. Not always, though.
I think it might be a good point right here. We say osteoporosis, we all know that it's weak bones, but the mechanism of action of how a bone breaks down and rebuilds, and then where osteoporosis seeps into this process. Can you go over that with us so we get, a visual of perhaps what's going on and an understanding that bone is just not dense structure to hold us up?
Well, first thing, bone strength is a combination of bone density and bone quality. And you can't just look at a person's bone density exam, their Dexa exam, and say, they have a T-score of negative 3.0, they're at high risk for fracture. Because that's just looking at bone density. They might have good quality, they might have poor quality. And different things lead to a loss of density, different things lead to a loss of quality. So it is a very hard game to play as far as determining each individual's fracture risk. And as a general statement, people lose bone density, people lose bone quality if they have an underlying level of inflammation in their body. And, that's pretty common for all chronic systemic diseases, depression, anxiety, cardiovascular disease, diabetes, Alzheimer's. They all seem to have a background of inflammation. And that does contribute to an increase in osteoclastic activity, which is the bone cells that break down bone, and a loss or a decrease in osteoblastic activity, the cells that build bone.
If you decrease inflammation, let's back up here a bit. Inflammation can be charted many ways. Blood tests can certainly give some indication of inflammation. Is this the first place you would go?
No, because there are lots of different lab tests, and just because a person has inflammation in their body doesn't mean that every lab test for inflammation is going to be high. For example, a high sensitive C-reactive protein, which is a protein released by your liver in some inflammatory issues, that may be high in a person. It may not be high, but it doesn't have to be elevated to say that person has inflammation. So a lot of times, you're right. You can test for oxidative stress markers. You can test for liver health, because liver congestion will increase toxins in the body, which increases inflammation. So there's so many different things that cause inflammatory issues. So I think what you look for instead is other issues, and that might be a person's symptoms, just fatigue, sluggishness, anxiety, different things, that they don't feel well.
Well, okay. So then the question comes, the question that comes to my mind is, if we look in a functional medicine perspective, inflammation is, I can't say 100%, but a very large part of most chronic diseases. Is that a truism? Okay.
That is true.
So if you are a person who has any type of chronic disease, looking at bone health should be on one of your checklists, I assume.
Definitely. I wrote a book 12 years ago called The Whole Body Approach to Osteoporosis. My new book's called Great Bones. And I think on that old book, The Whole Body Approach to Osteoporosis, you could have taken away the word osteoporosis and put in the whole body approach to, any number of chronic disease. And the reason why is because, yes, you're looking for a background of inflammation, because that does increase chronic disease of all kinds. The nice thing about, if there is a nice thing, there's always a silver lining in everything, I guess. But of finding out if you have low bone density early on, that's why the reason why it's important to get bone densities early is not only it's easier to fix a small problem, then it's much easier to do that than fixing a problem that's entrenched. But then if a person has low bone density, oftentimes then they can ward off other disorders because they're going to do the same thing to improve bone density. Well, little differences, but as they are going to be to improve other chronic diseases. And I'm not saying that every person with osteoporosis that's the problem, inflammation. That's not true either. Low bone density can be caused by parathyroid issues. It can be caused by thyroid issues. It can be caused by a number of genetic issues and things like that. So those all have to be ruled out before you say, oh, a person's bone loss is just because of inflammation. It's not always that way.
Okay. I've got 2 or 3 questions that are popping into my mind in all different directions. But you said something that the bone is, test should be for density and quality. Okay. So we get the density test done. That's a standard. Can quality, first of all, what is quality of a good bone? And can that make up for bone density?
It can. And one of the best tests, and probably the only real test out there for bone quality, is what's called a trabecular bone score, or a TBS. The good thing about TBS is that it gives you one aspect of quality, and that is the connectivity of the trabecula within the spine. If the trabecula, which are these little beams and struts that it's like the inside of an airplane wing, it gives the airplane wing the strength, but it allows it to be light. And the same is with your bones. We have these little beams and struts in there that allow bone to be strong, but when those little beams become disconnected, that's a poor quality of bone. Now, there's other quality issues, things to bone also that we can't measure, but at least that's one that we can. The problem is many hospitals do not have TBS capability with their bone density. So a person has to, if they want a TBS, they need to go look for it. They need to call up different hospitals and say, hey, do you guys have TBS capability with your Dexa, with your bone density exam?
So if you come back with a good bone quality score, can you somewhat disregard the density score?
Not disregard, but often if a person is, if a person is kind of on the borderline of needing a medication or not, if they have a good quality bone, sometimes they can get away without having to take an osteoporosis specific medication. But if a person has a negative 3.5 and they have poor quality bone also, then in all likelihood, they're going to have to do a medication.
Okay. So you mentioned a neurological connection to bone health. Am I wrong in that?
No, definitely there's neurological connection. There's vascular connection, neurological connection. So the nervous system does innervate bone, and it activates the ability for bone to remodel. The same with the vascular system. If you have a poor, that's why cardiovascular disease and osteoporosis go hand in hand, because you need good vascularization for bones to grow and to heal if there's a fracture. So yeah, both the neurology and the vascular system have to be, optimum.
The vascular system, I'm familiar with. I understand that. The neurological system never really dawned on me. So if you can strengthen brain and spinal health, you are going to be able to improve bone health.
If that's an issue.
If that's an issue. Okay.
You won't do anything to improve bone health if it's not an issue.
Fair enough. Okay. Who is most at risk? Because I said women over 50, but what are the other sort of boxes that need to be ticked off with regards to at-risk people for osteoporosis?
I think one of the biggest things I find is people of low weight and people who have lost a lot of weight. So if a person is 110 pounds and then all of a sudden they've lost 7 pounds, that's a major risk for losing bone density. It's one of the biggest things I see, but various medications cause bone loss. Depression causes bone loss. Sleeplessness causes bone loss. There's just so many risk factors for bone.
A functional medicine approach to this, then, what's popping out here is the education piece that seems to be lacking. I think for most people, osteoporosis is a disease of the aged. It's a disease for those who aren't moving well, so of that age over 50. And I think a common knowledge piece as well is low estrogen. But, if you could write the script for getting people aware of where they might go wrong in bone health, what would you do? Would you educate people when they're losing weight? Would you educate? Is there a way that we can start educating people so that osteoporosis, even if you're in a risk factor, may not come to fruition?
I think, your comment of we think of osteoporosis as being with older people. Well, one of the real reasons for that perception is that we don't get bone densities in people until they're 60 and 65 years old. So right away, we're saying, we're missing a whole cohort of people that are younger because we've never tested them. So I guess, as I said earlier on, I don't really look at risk factors. And the reason why is if 50% of the people are going to get a disorder, let's look at everybody. For me, I didn't have any risk factors either. So I so wish that somebody would have said to me when I was 40 years old, "Hey Keith, let's go get a cheap, a very inexpensive, non-invasive, easy to do test to see how your bones are." And the way to improve a person's bone health is to catch it early. It's very difficult to gain bone density later on. You can, but it's difficult. It's much easier to fix a person or change the course of their bone health earlier than later.
Should we expect loss of bone density as we age?
Super question. All the literature says that you do lose bone density naturally. And I think there's some truth to that, although some people I see who don't. But yes, as we age, we do tend to lose bone density. Women lose it incredibly fast for 5 to 7 years after they lose their estrogen at menopause. And then it typically slows down, but I don't think you necessarily have to lose bone density. I haven't lost any bone density in the last 20 years. And, but I always say to people, well, it's kind of natural to lose some bone density, but I don't think you have to.
Well, I have a question here because I've read certain people and certain comments, and they're talking about the Dexa, the baseline. Now, the baseline is, correct me if I'm wrong, this is not my area of specialty. The baseline is a 30-year-old. Is that about right?
I think it's 27. Yes. Yeah.
27 years old. Yeah. So if you have a baseline of the average 27-year-old male or female, or is it one for male and one for female? Is there two different numbers? Are there two different numbers?
Different countries use different parameters, so that gets a little complex. So,
but do you find, or do you feel that is a fair number to peg a 60-year-old's bone density to?
Yeah, they have to pick a certain age, and the reason why is because what they're trying to do is pick the peak bone mass. Of when a person reaches their prime, essentially, and then no, I don't think that's a poor way of doing it. We had to do it in some way, and we need to have some standard. The fact that the negative 2.5 was chosen for anything worse, lower than 2.5 is osteoporosis. Anything better is not. That's not completely random. They were assessing the percentages of fractures beyond that number. So what is most difficult with all those numbers for T-scores is that smaller women, and that's, I think, the biggest problem with this whole game is that like a person who's 100 pounds versus a person who's 135 pounds, the T-score of a negative 2.5 for that 100-pound woman is certainly, it's making her look worse than she really is.
Mm-hmm.
The bone density is a two-dimensional picture of a three-dimensional object. And so the smaller that person is, that bone density might not really be as severe as it looks.
Okay, fair enough. We're going to, sorry?
I think that's the biggest issue with the bone densities.
Okay. So not a bad gauge. We'll leave it at that.
I think it's a bad gauge at all. I want everybody to get a bone density.
Okay. I think we're going to take a quick break here. When we come back and talk further about osteoporosis, really going to hone in here on treatment plans, the formula for healthy bones. So everybody stay tuned. We'll be back in just a few minutes.
You are listening to The Health Hub here on Radio Maria Canada. A Catholic voice wherever you are. To contact us and be a part of the show, email thh@radiomaria.ca. We now continue with the program. Here once again is your host, Kathy Biasi.
Welcome back, everybody. Before we get into key treatments, health plans for healthy bones, I wanted to ask you about, we were just talking off air about this, fatty bone marrow. It's something that I came across when I was doing research for the show, and I had never, ever heard of this. Can you explain to us what that is and how that impacts our health?
Oftentimes when people get lower bone density, their bone marrow fills up with fat. And it has nothing to do with their subcutaneous fat. They might be a really, really thin, svelte woman of 100 pounds, but they can still have fat build up in their bone marrow. And the reason why this occurs in people more often, in people with osteoporosis, is because the osteoblasts are the cells in our bone that form bone. Well, those osteoblasts, they come from the mesenchymal stem cell, which is in your bone, and the mesenchymal stem cells differentiate or form into either an osteoblast or a fat cell. The problem is in people with inflammation, chronic systemic inflammation, it changes that differentiation process of those mesenchymal stem cells and pushes that differentiation process more towards the adipose cells, the fat cells, than towards the osteoblasts. So the person gets less osteoblastic activity and more fat in their bone marrow. The fat cells also release palmitic acid, which is toxic to the osteoblasts, and the fat cells also crowd out the hematopoietic stem cells, the cells that give us red blood cells. So that's why when you can tell when a person has the fatty bone marrow, because their red blood cell count is usually pretty low, 4.0, 3.9, 3.8. That's a pretty clear indication. It doesn't have to be, because there's other things that can cause a negative 3.8 for a red blood cell count. But oftentimes, if they have a 3.8, it's because of the fat buildup.
How many doctors would make a connection between low red blood cells and fatty bone marrow? I have never heard this connection. How do you test for it? This is a phenomenal piece of information.
I'd say 1 in 500. So not very many, but that's why I write about it in my books. So it's an important part. And a CBC, a complete blood count, is $5 or something like that. It's an incredibly inexpensive test, and it's a wealth of information. Looking at the ratio of white blood cells to each other, looking at the red blood cell distribution width is an important. Just looking at that in and of itself, with the bone density, is a good indication of fracture risk. There's so many things that can be determined from a CBC and a CMP, the Comprehensive Metabolic Profile. Very inexpensive tests, and people feel like, I do a lot of lab testing, and lab testing are a really important part of assessing a person with osteoporosis, but people don't realize there's so many gems of inflammation staring them in the face when they look at these as far as bone health. Yes, they're missing a lot.
Yeah, but there really hasn't been anyone to direct them to that. If you go and, you get your blood work back, you look at the number, you go to lab online or whatever, you try and figure out, low RBC count could be this. Never once have I seen could be because of your fatty bone marrow. I think it's a fascinating piece of information. Yeah. So sorry, go ahead.
I have a whole chapter in my new book, Great Bones, and it talks about all these lab tests and how I want a person to be able to go through their labs and say, oh, geez, this is a little bit high, this is a little bit low. Oh, this is borderline low, this is a little borderline high. What does that mean? And I talk people through that.
Yeah, and as related to bone, because we can relate it to other things, but not as related to bone. So, right. With all these positive things coming out and with you talking about all the impact of different things on bone health, can we say that osteoporosis now is something that you feel can be reversed? Because up to this point, no, it can't be. Can you improve, or are we maintaining where we're at when you find people?
It depends on age. A lot of times, as a person gets older, their mesenchymal stem cells and therefore their osteoblasts become less and less capable. And so after a certain point of age, then yes, it's much more difficult to improve. But that said, that's why we have medications. Medications are great if they're used wisely and short term. But the medications, the osteoporosis-specific medications can pull a person out of a really bad situation. And then by all during that time that we're pulling them out of a bad situation with the medication, then they're improving their whole body health in other ways, exercising, eating better, et cetera. And then they can come off the medications oftentimes, and then their bone health stays better.
Well, what are the drawbacks of staying on medication?
Oh, lots of drawbacks. The bisphosphonates, the reason why, okay, let's just talk about one type of drug, and that's the bisphosphonates. They decrease osteoclastic activity, and the osteoclasts are the cells that break down bone. So it's good to calm those osteoclasts down. The problem is you need osteoclastic activity to call out the microfractures that occur in everybody's bone every day. So every day people sustain little bitty microfractures. The osteoclasts then eat out those microfractures. The osteoblasts come in, patch up that what's called a resorption pit, and now we have new bone in place where that microfracture was. So osteoclastic and osteoblastic activity are important, ongoing, but bisphosphonates essentially kills off the osteoclast, and now we don't have even osteoblastic activity because you can't just take away osteoclastic activity without decreasing osteoblastic activity. So without that ongoing bone remodeling to get rid of microfractures ongoing through the years, we have a buildup of microfractures, and bone becomes old instead of fresh.
Got it. Okay. Now, one question I had written down that I forgot to ask earlier in the first segment. Does low bone density always mean osteoporosis?
No, definitely not. There's many reasons for low bone density, and all those reasons have to be ruled out. So yes, a person can have low bone density, but they might not have what's called primary osteoporosis. They might have a secondary osteoporosis because of a drug, because prednisone. A lot of people are on more than 5 milligrams of prednisone every day, and you do that for 3 months or 4 months, you're going to have bone loss. You can easily go into osteoporosis. And the problem is not that they have osteoporosis. The problem is that they're taking a medication that's causing them to lose bone, and now they have a secondary osteoporosis.
It's fascinating, all the factors that really need to be taken. I mean, we know it with other areas of health, but with bone, I just don't think we appreciate what bone does, number one, how it works, and the myriad of ways that all aspects of our other areas of health impact bone. So let's get on to how to stave off or how to maintain a level of bone density. You talked about being on medication and then working behind the scenes. What are the key aspects of a treatment plan that you put into place with somebody?
Diet is number one and exercise is number two. So in diet, if they have sensitivity issues such as dairy or gluten, then they need to get off of those. Gluten can cause bone loss in two different ways. If a person's sensitive, if they're not sensitive, then there's no reason to be gluten-free. But if they're sensitive, it can cause a decrease in their ability to absorb nutrients, and it can cause an increase in inflammation. So a person cannot have, so celiac disease is when a person is very, very sensitive to gluten, and it causes damage to the little villi, the little projections in the person's gut that allows for absorption of nutrients. But a person can have sensitivity to gluten and not have celiac disease. They can have no damage at all to their villi in their gut and still have bone loss from gluten. And the reason why is because I think one of the most important things I'll say today is this. Osteoclasts, the cells that break down bone, are a form of a white blood cell. They come from the same stem cell as your white blood cells come from. I'll say that again because it's so important. So your hematopoietic stem cells give you your white blood cells. They also give us the osteoclasts, the cells that break down bone. Why is that so important? Is because they talk the same language. A white blood cell, when white blood cells talk to each other, they talk to each other by signaling molecules. It's called cytokines. And those same cytokines also stimulate the osteoclasts. So anything that increases your immune system, anything activity, anything that increases white blood cell activity is also going to increase osteoclastic activity and a breakdown of bone. So if you have a sensitivity to gluten, even though it's not severe enough to cause damage in your gut, if it's increasing white blood cell activity, your body is now releasing more pro-inflammatory cytokines, i.e. inflammation, and that's going to stimulate the osteoclast to break down bone. So anything that does that, any increase in the immune system is going to increase osteoclastic activity.
So then back to the blood tests. My mind is going at warp speed here. If you get a blood test back and you've got elevated white blood cell count, should we be looking at bone as well?
I talk about a ratio in the that you can determine in the CBC, in the complete blood count, and you look at the ratio of neutrophils to lymphocytes, and yes, that will give you an indication of bone loss. It's called an NLR ratio, or a neutrophil to lymphocyte ratio. And yes, so it's a quick, easy, cheap way to look at your immune system.
That ratio is used in other areas of health, is it not, as well?
Yeah. Mm-hmm.
Okay. What about supplementation? So I'm assuming, I want to talk about supplementation and I want to get to your work. So I'm just going to sum up diet: whole-based or whole food, plant-based. Is that where you're going?
Yeah, plant, but making sure that you have enough protein. So eliminating those things that you're sensitive to. And then, yes, plants, they not only have important bioactive compounds with them that help limit or contain inflammation, but they also give us a lot of good alkaline minerals: potassium, sodium, magnesium, calcium. And those alkalinizing minerals buffer hydrogen ions that make our blood pH drop. And when blood pH drops below 7.3, that will then increase parathyroid hormone production from your parathyroid glands, which then stimulates the osteoclast to break down bone. So we need to keep that blood pH good. And one of the ways to do that is by eating a plant-based diet. That said, we need to make sure we get some, at least 60, 70 grams of protein a day, because what is bone? It's protein impregnated with minerals, but we need to have a good base of protein.
Thank you for that. When, a lot of practitioners will say get enough protein, but you try and knock down a number, and it's a hard one for people to put a number on. So 60 to 70 grams of protein per day. We have a ballpark. I know it's very individualized, but at least we have a ballpark. Now, is supplementation of any value?
It is, but don't rely on calcium as being the end-all be-all answer to osteoporosis. It's not. It is not necessary. Everybody needs a certain amount of calcium, but the real issue here is not calcium. It's the ratio, the relationship between osteoclastic and osteoblastic activity. You can take all the calcium you want, but if your osteoclastic activity is ramped up and your osteoblastic activity is poor, you're not going to, the calcium's not going to do us any good. But yes, everybody needs, I say 1,000 to 1,200 milligrams of calcium a day. So oftentimes I'll recommend to people 500 to 700 supplemental calcium, because they're going to get, if they're eating a good diet, even if it doesn't have dairy, they should be able to get 600, 700 milligrams of calcium, or more if they're eating, things like sardines and good vegetables and a little bit of dairy, but don't rely on dairy to get your calcium. But vitamin D, vitamin K, trace minerals, those are all incredibly important.
And exercise. Weight-bearing exercise?
You don't exercise, then number one, exercise stimulates your muscles. Your muscles then send myokines, they're signaling molecules, to your bones to say they're still needed. If you don't exercise, you're never telling your bones that they're still needed.
So running, anything, any type of exercise, any movement, or do you prescribe certain movements?
Brisk walking, you can't just walk leisurely, but brisk walking, running, light weights. There's a whole, I recommend to people that they go to a gym. Number one, if they pay for it, they're going to use it more instead of just doing a home program. But number two, there's often incredibly good either physical therapists or personal trainers that can teach you exercises to keep you engaged, but also safe. And one of the worst things to do is flexion of the spine. That puts a lot of stress on the spine. So flexion exercises put a person more at risk. Extension exercises don't. They improve the stability of the spine, whereas flexion exercises put you more at risk for fracture. So just simple little things like that. A personal trainer or PT can walk a person through and make sure they're safe.
I'm going to assume that if someone is diagnosed with osteoporosis, this is something they should be letting their trainer know, their physiotherapist know something, because it would be different types of care. This is just a personal question because it just popped into my mind. Is there an osteoblast osteoclast ratio that you can get?
No.
Okay, fair enough. Fair enough. I thought that'd be too easy.
But there are bone turnover markers that you can look at to kind of guess at that answer to that question. So a C-telopeptide is a bone resorption marker that looks at osteoclastic activity, that mirrors osteoclastic activity, and a P1NP, or what's called a procollagen type 1 N-terminal propeptide, is another blood test for osteoblastic activity. So I look at the CTX and P1NP is a ratio, and I try to go like a 10 to 1, 9.5 to 1 ratio, and that mirrors osteoblastic, osteoclastic activity, but it's not definitive right answer. You can't really look at the osteoclast or osteoblasts.
Okay.
But that's the best that we can come by. And it's not a bad way to go.
So my final question to you is this. Is the health of your bones a reflection of the rest of your health, or can it be an indicator of health?
Another super question. I think it's an indicator because, I think it would be better to say it was an indicator than a reflection, because there's certainly a lot of people with low bone density and their health otherwise is stellar. So, but not always, for sure. So,
because I think if you look at it that way, then you're a little bit more inclined to take the health of your bones more seriously.
Oh, definitely. It is I talk when I give a lot of lectures, I talk about your skeletal health, your bones as being the center of your universe. Mm-hmm. Your bones are connected to every single organ in your body. They talk to every single organ, and every single organ talks to your bones.
I find maybe it's just because of the path I'm going down, the people I've been talking to, this bone muscle health area is something that has been not well understood, but it seems to be picking up speed, the health of the muscle and the health of the bone for overall health. And, thank you so much for everything that you do. Where can people get a hold of your books? They're fascinating. Amazon, are they all over the place?
Amazon, and just calling my office. We can send people books also. But yes, either through my office or Amazon.
And perfect. And are you practicing now? Can people get a hold of you for consultations? Where's the best place to go?
Yeah, I do telephone consults, just calling my office, and go to my website, Keith at McCormickDC.com. I have a website that they can go to and find out what to send to my office, and then we set up an appointment and talk about it.
And you have a supplement company as well?
Yeah, a supplement company is called Osteo Naturals, and I sell several supplements specific targeting osteoporosis, skeletal health.
Wonderful. Thank you. So this has been so informative. I can't even begin to tell you. When my mind starts going and I'm scribbling down here, I know it's a great interview. Thank you so much for taking the time to join us today. It was really, really wonderful talking to you.
Thanks for having me, Kathy.
Everybody, we'll talk to you next week on The Health Hub.
You have been listening to The Health Hub, hosted by Kathy Biasi, here on Radio Maria Canada.